So next up, we have Brian Dunn. He's the Chief Behavioral Officer at Concentric Health Experience. He's a bit of a data guru, so what he'll be doing is sharing some insights and quantitative research and data into the motivators across audiences. So if you think back to when Susie laid out the audiences, we had the publics, we had the decision makers, we had the policymakers. What really is it that's going to motivate these various audiences to think and believe and act differently? So with that, welcome, Dr. Dunn.
Thank you very much. So let me say that I'm deeply, deeply honored to be in your company, and I have to thank the Roundtable and thank you all for the invitation. I'm Brian Dunn. I'm actually an affective neuroscientist and experimental psychologist by training, translating essentially concepts and methodologies from behavioral economics into marketing strategy. So I want to speak briefly and show you, rather than tell you, how these concepts come to be embodied in public communications. In the interest of disclosure, this work is paid for by Novo Nordisk, and what I'm going to show you are campaigns that are in support of a branded anti-obesity medication and disease awareness efforts that Novo Nordisk is engaged in. So there are many of the themes I wanted to touch on have already been brought up. So let me just try to pick up all the threads that I noted from the first session. One has to do with what we would call the fundamental attribution error. So much has been said that boils down to that. If your attribution, which is especially when it's an automatic attribution as a physician or a person in the public, is that a person with obesity has a characterological problem, what follows from that is a limited set of solutions. And this fundamental attribution error exists across social biases. It exists in the domain of poverty, it exists in the domain of unemployment, and in some sense it's the same mechanism. So the fundamental attribution error here is being debiased with images. This is an implicit debiasing campaign. And we have found over the years, and I'm translating straight from the lab, that these implicit communications are more powerful. You do not tell someone, please stop being racist. It doesn't work that way. What you do is show them a narrative. You use symbols and implicit messages, especially in social media and digital media. So this campaign is really, in some sense, an implicit way of saying what we want to say about these individuals, and that is that they are diligent, they are involved, they have energy, they are not lazy, etc. You have, for example, video assets in which each of these characters, these heroes, engages in a 14-hour nursing shift and then comes home and makes food for the family. Certainly not someone who cannot control their behavior. An exceptionally difficult life. I've worked in nursing. Those shifts are really difficult, okay? You get your 3 to 11 and 11 to 7 a.m. and then come home and cook for your kids and get them to school. I don't need to say this person isn't lazy. The narrative tells them that. Seen over and over again, shown over and over again, and shared over and over again, what we're doing is we're manipulating an attribution built into that creates an availability heuristic, in essence. So you know well from behavioral economics that the ease with which something comes to mind is an index of how true it is, unfortunately. And when you look at these webs of mis and disinformation, very, very dangerous information comes to mind very quickly. Stereotypic information comes to mind very quickly. It's been programmed to be such, just as a function of frequency. Thank you, Dr. Kahneman. So, countering these errors means showing the counter-narrative with relatively high frequency. That's our job. We need to make this viral, and each one of these characters has a narrative. You know, the police officer is a military veteran, he works out every day, he boxes. Each person, respectively, gets us to those micro subgroups. So this is cast very, very deliberately so that we are speaking to the stakeholder groups in as much as we could. Obviously, there's a limit to our casting and how many videos we can make, but this was the purpose. one of the other things that's a bit of a pet project for me is that the psychology of connectedness is often absent in communications with regard to obesity, especially with regard to weight loss and management. If you think about it, and some of the images we've seen this morning already show this, there's a fundamental narcissism in weight loss representations. You have a person alone reflecting back on their own body, alone always. A person concerned with their appearance. So when we wrote these narratives, and I'm briefing the creative team and reviewing the scripts, all of these people are doing something for others. They're connected to others. It's another way of talking about not being lazy. They're also not self-involved. They're caregivers. That's a counter-biasing narrative. It's essential, and it's true of them. It's a socially rich life that they live. And they're depicted naturalistically. I have a deck, which time won't allow, in which I analyze every single feature of all of these images. But let me tell you, it is hyper deliberate. The actions, the postures, the casting, and so on. I'll be happy to answer questions about that. But we represent the diversity of our nation. We accurately represent the epidemiology of the disease state in this campaign. And we represent the actual struggle and effort for lifelong, long-term weight management. Not merely short-term weight loss, but weight management as a health goal, a global health goal. This is the reorientation, the cognitive reorientation that we are driving here. So my colleagues and I at Novo are thinking that big, and that's where it has to go, I would argue, respectfully. So now I want to pivot and show you another arm of the work that I do, which is in quantitative linguistics. Much has already been said about the struggle to sample accurately, sample the US population accurately. And I would respectfully suggest that one of the ways we can do this is using quantitative linguistics on social media data. So I work with my esteemed colleagues, Glenn Coppersmith, Alex Fine, and Tony Wood, who are both psychologists and data scientists. And we share this background. And the projects that we do are at the intersection, the overlap of mental health, physical health, and social interaction. So what I'm going to show you are preliminary data. Again, this is a Novo Nordisk study, internal, doing what's known as digital phenotyping. So in order to solve the problem of non-representative sampling, we have incredibly rich publicly available data in social media. Massive, massive data sets in language and images. And it cuts across, at this point, because of the user bases, all demographics, all socioeconomic groups, all ethnic and racial groups. And cutting these data down to very, very fine-grained subsets is possible because of the sheer volume. Everyone, in essence, almost everyone is represented. To be frank, the group that is least represented is a group over 70 currently. But as we age through, you'll see. So if anything, this sample is underrepresented for people who are over 65 or over 70. So just to give you a crude sense of this is very early days. These are preliminary data, but we begin ingesting a massive amount of social media data language. At this point in the study, we were over 300 billion messages, right? So we began the morning looking at volume. The volume is stunning, but to ingest, which means to capture the simplest and cleanest data sets, we have methods that I can answer questions about as we go later, but we start out with Twitter, public forums, and a few other social media inputs, and we run huge volume per day. So this ticker, this should actually be scrolling. At the moment that I made this slide, it was over 300 billion. We got down identifying, we were interested first in a model of self-identification. So the natural language processing syntax is simply first-person pronoun, 1 to 4 units, and adjective. So people are disclosing. And to get to the studies about people's preferred terminology in the clinic, it's actually paradoxical, because people in their self-disclosure totally violate what they would like physicians to say, the terminology that they would like to be addressed with, and the terms they would like to use for the disease state. People, I mean, it's social media. So we have all modes and all tones. We have sarcasm, and we have much else besides. Social presentation. Much of this is in the mode of socializing, in the romantic sense, partially. So we got to a point of the identification criteria being satisfied by about 4,500,000 messages at this moment in the study, with using a set of keywords beginning with just simply, I am overweight, I have obesity. But then we realized that skewed the sample toward men very, very strongly. So we readjusted, and one of the things we entered was a set of verbs that we thought that women were much more likely to use. I feel, I look. Guess what? We found them. And using terms like curvy, busty, etc., gendered terms, people are using those terms. It's just a simple fact of the language people use on the platforms. So and then we have a model for comorbidities that I can discuss, but this was, I was stunned first at how likely people were to disclose. We've worked a lot in diseases that have very low disclosure rates. For example, in postpartum depression, we've built excellent and accurate models. But in this case, people were very, very open and very explicit, actually, in their disclosures. So we've developed a cohort, a very fine-grained cohort, a research-grade cohort, for a prevalence sample of approximately 4,000 females and approximately 7,000 males. This is, to avoid getting into too many methodological discussions, this is trimming off the over-posters who are 2 standard deviations above the mean. There are many people who will skew your sample because they say so much, and they say so much about everything. We get them out. We also have sorry if you're an over-poster and you're tweeting this right now, but we may have eliminated you from the sample. We also take out the very young samples that also tend to skew our data because their rates are different. So the under 25 sample is left out of some of the graphics that I'll show. We then build models for psychographics. In this case, we are interested in people who are talking about treatments and people who are interested in treatment seeking. And we can go down to geo-target a subpopulation of them, and we're using a set of zip codes that's provided by Novo Nordisk for areas that have optimal coverage. So let me just show you two data points. Just squint at these data. It has been said that we live in a polarized nation, and much research has been shown to try to identify the factors that polarize discourse. This is actually suspiciously polarized as a data set. This is all of the statements about overweight and obesity in the identified cohorts over time, rated by sentiment. So this is, let's say, emotional valence or sign, positive and negative. And the near symmetry of positive and negative discourse is stunning. And the frequency is less interesting because it is a fairly low frequency thing to say. We had hoped that we would have more, let's say, people who are outside the discourse, more mavericks, more people who are in the vanguard, because we're really going after, what Cass Sunstein describes as people who are receptive and ready to change. The red group, they are there. They are a smaller population. Clearly, you could go into this sentiment. I could click through this if this were live and show you, but we will be talking to people on both sides. My personal hypothesis was that negative valence, negative sign, would be with, let's say, psychological distress or indicators thereof, would be associated with stronger treatment seeking. That people would reach a point at which they had cycled through enough treatments and attempts, and they would eventually move to medical management, long-term management of their weight. And we may see that, but the data on social don't show it so powerfully. So it may be a subgroup or sub-subgroup, but this is what we see. And interestingly, one of the things that we do is we move from the standard direct, explicit disclosures to much more complicated, sophisticated models, statistical models, in which indirect language classifiers are built. So you build outward from the disclosure to word embeddings and what's known as language-based classifiers. Those find much more subtle semantic and linguistic relations, and that's where things really get interesting. To take one example, that's where we start to see the sign of, let's say, people of color using the word thick, T-H-I-C-C. One of my younger colleagues had to explain to me what this is and give me a set of references of recordings to listen to, but it's a description of the body, of the body as positive, and it's ultra high frequency in this sample. So we have found people of color as a function of the use of a specific term, and now we can use that term to communicate with those people and the terms that surround it. Just to give you one example, those data are really, really interesting and were news to me. Lastly, I can't leave you without communicating the point that there is profoundly and consistently negative expression regarding emotion and physical states. It was said earlier that people are confused. Yes, people are confused, but people are also suffering tremendously. Leaving aside the actual comorbidities with mood disorders, this discourse is very dark across age groups, in terms of speaking of one's own emotional states and physical states. So when we're speaking to people, regardless of group, we should speak to them knowing that they're in that place and knowing that this is the territory that just consider the red boxed area. This is the emotional territory they inhabit. I've never seen sentiment data like this about any subject, including in mood disorders. It's more mixed. Postpartum depression, for example, major depressive disorder, much more mixed. So this is in some sense the secret history of the emotional state of this group, and they should be treated and spoken to appropriately. Thank you very much for your time.